Well, hey guys, welcome to this pharmacology review on the drug class potassium-competitive acid blocker. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from the what to the why. Now, this drug class is the newer kid on the block in the category of antacids. You know, when additional treatments come to market, we all have to learn about them at some point. Now, this drug class originally debuted in Japan back in 2015. In late 2023, it was approved in the United States. Now, its indications are unique, giving it a place in therapy. In my 30 years of experience as a nurse, pharmacist, physician, I have found that when I have learned to understand core medical concepts, no matter what the topic is about, then we are more likely to be equipped to learn new content more efficiently as it comes out. So why is it relevant to learn about the potassium-competitive acid blocker? Well, one, it's known to be an alternative to patients on PPIs who are not adequately responding. It has a rapid onset of action that can get that gastric pH greater than 4, which is necessary to facilitate healing of the gastric mucosa, especially in more erosive conditions. In addition, it has an impact on basal acid output. And this can be very helpful, especially also in conditions like H. pylori and erosive esophagitis, where this drug is being used. So what medication, and I use it singular, it makes up this class? And it's Vonoprazan is the generic name for it. Now we need to understand some of the indications, and now that we understand a little bit of its relevance. So I'd like to take us into a table that puts this drug and its drug class in comparison to the other classes of antacids, the H2 receptor antagonists and PPIs. Okay. This table has a lot of information in it, but you'll see that it's a summary of all of the antacid classes that make up that category. So we have the H2 receptor antagonists on top here, and then we have the PPIs, or proton pump inhibitors, and then our potassium-competitive acid blocker, Vonoprazan. Now, when we look at the indications, you'll see GERD, you see dyspepsia, peptic ulcer disease, H. pylori, erosive esophagitis, and then duodenal ulcers, and then hypersecretory conditions like Ehlers-Danlos syndrome, and then lastly, GI bleed. Now, with any medication, especially newer, it's going to evolve and gain indications over time, so this may evolve and change. That's okay. It's not to be unexpected, to be honest with you. But it very much aligns with the PPIs, especially as it relates to GERD, H. pylori, okay, H. pylori, and erosive esophagitis. Again, a good alternative option for this patient population if they should not respond adequately. Now, how then do this medication and its unique indications align with the mechanism of action? And I'd like to give you a quick overview of some of the basic anatomy so that we can put things into a context. When we talk about erosive esophagitis and we talk about GERD, how does the anatomy align to that? H. pylori, what's going on at the cellular level? So we'll cover all of those here now. Okay, let's jump into the anatomy. I'm a firm believer that when you learn a disease state, drugs and pharmacology, that you understand the context of where these drugs are working, also the anatomy they're impacting for the indications that you're using them for, because that guides us. It guides us to understand, is the drug getting to the site of action and exerting the desired pharmacologic effect? And if not, why not? Okay. On top of that, it also is helpful to learn anatomy, because if something isn't working right, especially in this context of antacids, there's some bad outcomes. We heard indications like GERD that can eventually lead to erosive esophagitis. You heard a condition called Barrett's esophagus that can be precancerous. We heard the word peptic ulcer disease, duodenal ulcer. The duodenum is part of the small intestine. Why do they get ulcers? And then lastly, why do they develop GI bleeds? What is the deal with the blood flow? Well, that comes back to the anatomy. So it's important to have a framework in the context of the antacids in general. How do they work similar? How do they work different? What conditions are we treating? So that's what we're going to spend some time looking at here now. Please stay with me. It makes sense and it brings everything back together. Please don't bypass this section because it is relevant to your understanding of the why. Now, we partner with a service known as anatomy.app. Excellent service. You're going to see some great anatomy, three-dimensional structures. They do a fantastic job. We also provide you a link, a referral to that if you need that kind of service for your own knowledge or studying. Again, we highly recommend it. So let's now jump into the board here and look at the anatomy. So first I want to point out some normal anatomical structures. We have the aorta that's coming off the heart and going to the branches that would go to the upper body and then down to the lower body. You also see there is the esophagus, and it comes down through the diaphragm, and the stomach sits below and underneath, tucked up under the curve of the diaphragm. And the first part of this small intestine, which is the duodenum, is right here. Now, why does it matter to recognize this? Well, the esophagus is where that erosive esophagitis is happening. It's also where patients develop GERD. Well, why do they develop GERD? Well, if we zoom in and then also look underneath, you can see that there's an opening in the diaphragm at this location that is helping you to see where the esophagus enters into the stomach. If that band of tissue or that area gets compromised, then acid from the stomach can move up into the esophagus, which it does intermittently, but then we need to get it out. So if it spends too much time up in the esophagus, it's going to cause GERD, and it can lead to erosive esophagitis and eventually lead to a Barrett's esophagus. Now, the stomach can herniate itself up through this hole and stick out on top at this level right here. That is called a hiatal hernia. And with a hiatal hernia, patients can have ongoing symptoms. And that's why it matters, because if you're not responding, that may be because they need a surgical correction of the problem. Now let's take a moment and let's look at some of the anatomy of the stomach and specifically the blood vessels, because that goes back to GI bleeds and peptic ulcer disease. So here we have, you can see the anatomy of the stomach in more detail. Over here is this spleen. You can see that the aorta is coming down and there's a lot of branches coming off. This is the celiac trunk right here. There's a branch going up, there's a branch going over to the spleen. And so these arteries supply large volumes of blood to the tissue. But you also see that we have the common hepatic artery, and then eventually we get down to the gastroduodenal artery. Now it's a smaller artery, but it's feeding the duodenum, the gastrum and the duodenum over here. Well, when you have somebody with a duodenal ulcer and that blood flow is impacted, okay, so you can see down in here, this gastroduodenal artery down here is feeding the duodenum. So if you have a posterior duodenal bleed, those patients can bleed like crazy and die from that. Obviously, if you impact the gastric, the gastroepiploic arteries here in the gastric, you have this, the big curves and the smaller curves of the stomach, and you see all these blood vessels going to it. If we erode through that, then you can cause the blood to leak in there? Well, that's blood coming right off the aorta. It's under high pressure and volume. And so that becomes very relevant to explaining why those conditions become so important for us to manage. Now, let's go to the stomach itself. So when we kind of start to zoom in now, this is where we're going to see the cross-section of the stomach. We're going to eventually zoom in and get to the cells. We have chief cells and parietal cells that make up the lining of the stomach. You'll see here in a second that inside the stomach in this cross-section, there's a lot of folds. And in these folds, you see that can expand. Well, that's so that when we consume food, it can stretch, right? But down at the cellular level, that's where those blood vessels are coming in from that blood supply we were just talking about. But it's also where these cells reside. Now, think about the anatomy of this. So if we kind of zoom in a little bit more, again, you can rotate around and see the stomach in all of its angles. But let's say we put a band around here, or we remove a portion of the stomach to make it smaller. So in gastric bypass, then we remove these cells. Well, if we remove these cells, we can also remove some of the normal physiology. And so these are where patients start to develop problems with B12 deficiency issues, absorption of other nutrients become a problem, but you also change the capacity of the stomach. Okay, so now that we saw the basic anatomy, we're now going to zoom in at the cellular level, and we're going to look at specifically the parietal cell in the context of how do these drugs work after they make it to the site of action. Okay, so now we've zoomed in and we're looking at an image, generic drawing, of the parietal cell. So on this side of the parietal cell over here is the luminal side. Okay, it is the apical membrane running along the lumen of the inside. So there's those folds. On the other side is what we call the basolateral membrane. It's the side that communicates and talks with mainly connective tissue and the blood vessels. So the blood flow coming in, feeding these cells. So again, if you erode down and you got a blood vessel coming in here, you can cause a bleeding ulcer. Now there's a couple components on this image that are important for you to recognize. On the luminal side, you see that we have something called the hydrogen potassium ATPase pump. Is a transporter. This is the proton pump right here. This is the proton pump. Here's a proton pump. You got a lot of them. Now, they're the ones that are outputting hydrogen ions. And when those combine with chloride that are being transferred through, okay, then you form hydrochloric acid. And that's what generates the pH, makes the environment more acidic. On the basolateral side, you see we have a large number of receptors and things that turn on intracellular biochemical reactions. Some that activate, which will turn on acid production. Some that are inhibitory and will reduce acid production. There's a balance. So when you look over here, we have acetylcholine that can bind to a muscarinic receptor via the vagus nerve. That's our parasympathetic nervous system. So when we want to eat or we start to eat food, we go into this fed state. That's a parasympathetic response. That means the acetylcholine levels via the vagus nerve are feeding in on that muscarinic receptor. Then we have gastrin coming from the G cells binding to the PCAB receptors. And then you see histamine right here binding to the H2 receptor. H1 receptors reside in other places in the body, typically associated with allergic reactions. Then we have somatostatin and prostaglandins, which are both turning on inhibitory pathways. So prostaglandins become relevant because if you think about drugs like NSAIDs, NSAIDs are known to cause gastric erosion and irritation. They can lead to ulcers, so can aspirin. How does it do that? Why does it do that? Well, we'll go into more detail in another episode, but in short, prostaglandins are inhibited by NSAIDs. So we block this inhibitory effect. That means we're going to facilitate acid production. But NSAIDs also affect the blood flow in through the basolateral side, because prostaglandins, specifically prostacyclin, is known to be vasodilatory. So if we wipe that out, we reduce the perfusion coming in. We also reduce the inhibition by the prostaglandins on the parietal cell, and we create an environment or milieu that favors erosion and ulceration. So when you understand some of these basics, then the drugs begin to make sense. Well, what if we want to neutralize just the acid? So you're just having some dyspepsia and indigestion, and you want to solve it quickly, right away. Well, the easiest thing that you can do is grab the antacid, over-the-counter antacids like Tums, Maalox, or Mylanta, and just take a good swig, Gaviscon, all those kind of, they will neutralize the gastric acid almost immediately on contact, okay? Now, the problem with that is that it's not long-lived. It's a short effect, okay? That means you'd have to keep repeating the doses throughout the day, which is not feasible and could expose people to other things that you don't want them to be exposed to. Too much calcium, too much aluminum, all these things, magnesium. They cause side effects. So it's not a very effective agent, especially if you have gastric ulcer and need healing. So oral antacids like Tums, Maalox, Mylanta are helpful quickly, but they don't serve for treating underlying problems. That's why we don't see it for H. pylori. That's why we don't use it for ulcers. If you want to get more acid suppression, the next easiest option is the H2 receptor antagonist. It's available, again, many times over the counter, and when you give this drug, you are blocking one of the receptors, not all of them, one. And so you will block this activation, which will slowly reduce some of the hydrogen ions. But like I said, it doesn't eliminate all of them. You still have other things turning on the proton pump. And so over time, the use of H2 receptor antagonists can lead to a condition or development of tolerance, breakthrough acid production. Because you are also not fully suppressing all of this hydrogen ions, you are not generating the gastric pHs above 4 for a longer period of time that's needed to create healing, like a PPI can, or like something like a potassium-competitive acid blocker can. You have to do something else. It's not going to work. That's why we want to be careful that if patients are not improving, at some point, we have to change and adjust the medications around. So how did we do that? How did we overcome that? Well, that's where the development of the proton pump inhibitors came, and as well as the potassium-competitive acid blocker, okay? They work at the proton pump. It doesn't matter what turns on the cell. It doesn't matter what's triggering it, what intracellular biochemical reaction, it doesn't matter. At the end of the day, it blocks the final movement of those hydrogen ions out into the lumen. And so obviously they're more effective. Now PPIs do that in an irreversible manner. That means they form a covalent bond with the proton pump, and they're there for the life of that pump. Now, thankfully, parietal cells in your gastric mucosa are turning over every couple days. So once you've administered the medication, it may be gone from the blood, but it is stuck on that proton pump for the life of it. That's good. That generates greater acid reduction, reductions in production of it. It makes the gastric pH more alkaline, achieves those goals of greater than 4, and definitely can get up to greater than 6, where if you have active bleeding, you can facilitate some coagulation. It also avoids, there's no tolerance. I mean, it's just check boxes. It's great. It also allows for once a day administration. Now, what about the potassium-competitive acid blocker? Well, yes, it works on the same proton pump, but it competes in a different location, and it's a competitive inhibition. But it's a pretty tight competitive inhibition. It has a pretty decent binding potency, if you will. And so the duration can be greater than 24 hours. In fact, it also works on basal acid production, which can be very helpful when you need to heal, especially at night. Now, sometimes we will use combinations of medicines together to maximize the effect, especially in very difficult to treat patients. But these two drugs right here, drug classes, are the ones that are going to exert the effect to provide treatment for H. pylori over a 2-week treatment. They're very effective for treating peptic ulcer disease and duodenal ulcers, especially if they're actively bleeding, because you've got to get that pH above 4 and specifically above 6. So I hope that brought together how the drug classes kind of interact and work with each other, how they're similar but also different in many ways. All right, now that we have kind of a framework on how it works, where some of these conditions are happening, let's talk for a moment about a few pharmacokinetic factors, pharmacodynamic factors that influence the way we use vonoprazan in clinical practice. So again, we have another table, again, summarizing the various drug classes inside the category of antacids. So we have the H2 receptor antagonists here on, again, top, proton pump inhibitors in the middle, and then vonoprazan down here at the end. Now, tables like this, I know for those of you that are watching this, sometimes a little bit hard to read or see every little detail. These tables are available at thisiswhy.health. That is where we house things in collections playlists, and for people who sign up for a free membership, you can get access to some of this information along with access to the collections and playlists to help you study or use it for your needs. So feel free to go there and download these for your personal use and study, or share them with others. You can also use them for your own teaching purposes if that's helpful. All right, so when you look at the bioavailability, we're down here at the bottom in the area of absorption. And you say it's not clearly reported, because it's not. At the time of recording this, the package insert doesn't even include the percent of bioavailability. But it's understood to be pretty well and adequate. Once it gets in the body, and then obviously distributes to the parietal-cell, where it's going to exert its pharmacologic effect. And you can see that it's a substrate of multiple phase 1 metabolic pathways. That includes cytochrome P450, 2B6, 2C19, 2C9, 2D6, 3A4. It also can have some weak inhibition of 2C19 and 3A4, so that can be associated with drug interactions. We know there's quite a few substrates of both of those phase 1 metabolic pathways. Now, the next thing I'd like to point to is the onset of action. You can see that's 2 or 3 hours. That's pretty good. You also see that it doesn't have a super long half-life in the blood. However, it has a very strong competitive inhibition, okay, to that hydrogen potassium ATPase pump that allows it to provide greater than 24 hours of antacid effect. And again, we're achieving similar gastric pHs, if not greater in some aspects, to some of the proton pump inhibitors. So that allows us for once a day administration. That's good. That's helpful. It's easier. Patients want easy. Clinicians want easy. We don't want to have to think too much if we can, or we want to avoid problems if we can. You can see the drug is renal eliminated, 67%. So pretty straightforward, simple medication. Overall, not too many issues. All right, now what about common side effects? All drugs have them. Shouldn't be surprised that this one doesn't either. Well, it's very similar to the PPIs. And so I'd like to jump back into a table to guide us through that. All right, so when we look at the proton pump inhibitors, I put this slide in here in particular because it's very similar to this drug in particular, vonoprazan. So same problem. So when you see here, you see up at the top, potential adverse effect. We have infection, and there's also not just infection of like pneumonia from aspiration, but enteric infections like C. diff risks, but also in certain patient populations with cirrhosis who can be at greater risk of SBP, spontaneous bacterial peritonitis. Now, you also see there's various risk factors and who are more likely to experience some of these. So we always need to put potential adverse reactions in the context of those risk factors. And so patients who are hospitalized, laying flat, bedridden, more likely to aspirate are going to be at greater risk of that pneumonia. Patients traveling, especially to endemic areas, are more likely going to be exposed. Patients on multiple antibiotics with these drugs can increase that risk of enteric infection. And so we just changed the gastric flora. Now remember, we need acid not only to digest food, but we also use it to be protective. So you can start to colonize the stomach, and that's where some of this risk goes up. Now it can also impact the absorption of other nutrients, one of them being magnesium. That's the second one listed here. And when you lower magnesium, you can also cause a hypokalemia. The maintenance of potassium in the body is specifically intracellular concentrations, which is where this cation predominantly resides, needs magnesium for the transporters to keep that maintained. So if you have a low potassium, i.e. hypokalemia, and you are also hypomagnesiemic, low magnesium, then you are more likely going to have trouble correcting the potassium deficiency unless you fix the magnesium first. And that is why we commonly check a magnesium level in the context of a patient also experiencing low potassium. You should correct the magnesium first, then you can correct the potassium if you want to not only replenish the potassium but maintain it, especially the intracellular contributions. Why does this also matter? Well, when you have both of those electrolytes low, that does increase the risk of cardiac rhythm changes, in particular widening of the QRS, prolongation of the QT interval, which then can increase the risk of torsades, which is a more life-threatening ventricular dysrhythmia. So remember, hyponatremia, hypokalemia, hypomagnesemia, hypocalcemia are all electrolyte abnormalities associated with QT prolongation. So this stuff matters. Long term, magnesium is also necessary for bone health. So it's not just calcium, it is also magnesium, collagen, other connective tissues. The next is vitamin B12 levels. So certain, again, things need an acidic environment. There are binders of B12 in our gastrointestinal tract that help move vitamin B12 throughout the system until it gets absorbed. There's also intrinsic factor, and that we're dependent on some acidic environment. So when you change the gastric pH to more alkaline, you decrease the absorption of B12. Well, that becomes relevant in patients who are maybe vegan. Okay, that means they're not ingesting anything animal-based. So they technically need to be on supplementation for that to not happen. Long term, this can lead to posterior column demyelination of the spinal column. That can lead to various neuropathies and some weakness neurologically. Now, bone density is the third and last one that I wanted to mention, which goes back to the magnesium. Okay, so this may impact the vitamin D levels, especially in smaller patients, so more petite, small body mass. There's a decrease in the overall calcium, and then of course the magnesium. Those two are components that are necessary for healthy bone. So again, these drugs, while they're some of them, like proton pumps inhibitors, are available over the counter, Vonoprazan is not, but these drugs are not benign. They can cause problems, and it's worth keeping on our radar. Now, what about drug interactions? Well, there are some drugs that depend on a gastric acid environment for adequate absorption. And one of those is a medication used in the management of HIV, rilpivirine. That's an NNRTI, that's a non-nucleoside reverse transcriptase inhibitor. Again, there are certain medications I'm getting ready to tell you here that you need to have absorbed in the body for them to work. Concentrations matter. And rilpivirine is one of those that requires a gastric acid environment, but it's more acidic in order for adequate absorption. Now, there are other drugs that are also dependent on the gastric pH to be more acidic. So we talked about rilpivirine, but the protease inhibitor atazanavir, itraconazole capsules, not the solution, tyrosine kinase inhibitors known as dasatinib and erlotinib, okay, which are basically used for cancer, and then clopidogrel at some level. Clopidogrel is not so much for the acid, it can be through the 2C19 activation. So remember I mentioned that Vonoprazan can be an inhibitor or interfere or compete with other substrates through that. So that's where that one would be. And that is one of our ADP inhibitors or P2Y12 receptor blockers used in cardiology. All right, so now that we've reviewed the brand name, the mechanism, some indications, side effects, some of these drug interactions, what are some of the monitoring parameters that we need to keep in mind? Well, I think it makes sense, guys. I mean, it's not rocket science. Think about it. The point of explaining the why and that we are learning to understand is it makes the prediction of what you're going to monitor pretty easy. So don't make it more complicated. Clinical signs and symptoms. Are their symptoms improving in their condition? Whether it's GERD, esophagitis, H. pylori, whatever. How about labs? Well, you heard about magnesium, you heard about calcium, you heard about vitamin B12. How would you assess vitamin B12? Well, you could also see it on a CBC and the RBC indices, MCH, MCHC, MCV. Those can be elevated, okay, causing a macrocytic pattern. Okay. Patients can, with long-term B12 deficiency, develop neuropathy. What about our special populations? Remember those drug interactions? We got to be real careful with simple antacid, like most people don't care. It's like a benign medicine. No, it's relevant. Patients who are immunocompromised and at higher risk for infection, they don't need extra risk of infection. Why would we do that? So we need to watch that and be careful and weigh the benefits and risk of this drug. What about counseling? Well, that should coincide. We can't tell the patient all of this information. That's not the goal here. But if you are concerned about their future use of certain medications, what they just basically need to know, you don't have to list them all off. They're not going to remember all those drugs. It's just like, hey, you're on a medicine that is known to cause some drug interactions with a few very relevant medicines. So if you get started on it, make sure you talk to the person prescribing it to you, or just give us a call and let us know. Now, there's also another counseling point. It's a little different, a little weird, unique. And this one is that if you're assessing somebody for a neuroendocrine tumor, I know, that's kind of weird, but there is something that you can measure, which is a chromogranin A in the blood or serum. And you need to stop Vonoprazan 4 weeks before you are going to measure that. Now, that's not something you're going to, counsel the patient on up front. Like, why are you talking to me about a neuroendocrine tumor, Dr. Busti? Why are you mentioning that word? I'm not taking this medicine. End of discussion, right? So I'm not going to tell them that. I'm going to counsel them if I see that medication on their regimen and if I'm in the unique scenario where I need to check that lab. So drug interactions, drug lab interactions, drug food interactions, all of these things are relevant. Okay, well, I hope that you found this topic review helpful. We have many like it and also others in this drug category available in playlists put together for you, also in collections. So if you need it for studying, or you want to review a topic area or an organ system, or you have students, residents, fellows that you want to have listened to some topics so that you can move on to other things. That's what these shows are here for. These episodes and reviews are here for you to use and to help you, help each other out. Again, there's also at thisiswhy.health, not only those playlists and collections, but notes. We also send out newsletters, new topics, new updates, so that we can invest in your knowledge so that you can help patients on a daily basis better than you may otherwise. All right, so this is a unique mechanism, offers another alternative to a PPI with adequate gastric acid changes that can facilitate healing and can also be used for things like H. pylori, erosive esophagitis. But unfortunately, just like PPIs, have very similar side effect monitoring parameters that we all need to keep in mind. All right, guys, so as we summarize, this is a medication in a unique class, has a unique mechanism, but is a good alternative basically to patients not tolerating PPIs. It's good for erosive esophagitis, H. pylori, but like PPIs and its impact on gastric pH, it can have very similar side effects, which lead to monitoring parameters and some counseling issues that are very similar. I hope you found this topic review to be helpful, and if so, give us a like and subscribe if you're watching us on YouTube. If you have not visited thisiswhy.health, go over and check it out. Again, we got those collections, playlists, and other tools for you available so that you can study, share, use the information to your needs so that you help patients. And I'll look forward to seeing you at the next topic review. Take care. Bye-bye.